Hi everyone, my name is Gabriel Altit. I'm a neonatologist based in Montreal. I practice targeted neonatal echo and neonatal hemodynamics, and I run the Neocardio Lab, which is a platform on the web under which you can find possibly certain interesting resources for educational purposes. And I also run the hemodynamics fellowship at McGill University and the Montreal Children's Hospital. And today I'll be showcasing some cases of pulmonary hypertension in context of bronchopulmonary dysplasia. So I will share my screen, and this will be under the context of cases. If you go on the website, you will find that there's a lot of resources related to pulmonary hypertension, pulmonary vein stenosis, especially in the context of prematurity. And the goal today is not necessarily to go over some of the basics of pulmonary precapillary or arterial pulmonary hypertension or post-capillary issues, or the fact that bronchopulmonary dysplasia on its own is a very particular condition affecting the lungs, the airway, and the pulmonary vasculature, both arterial and venous, because we know that the lungs of these babies tend to be heterogeneously affected. And so it's not like a homogeneous disease of the lung. And it's really something that tends to change in time. The good news is that often these babies will get much better as they grow and their lungs are getting better. So it's one of the type of pulmonary hypertension that will have a tendency to get better with time, contrary to other types of pulmonary hypertensive diseases. But obviously, it can present in various shape and form. Um, and because a large part of our evaluations in targeted neonatal echo or neonatal hemodynamics, as well as for colleagues in cardiology who practice in institutions where there's no TNE and they're responsible for evaluating these patients, well, there's obviously, you know, a large caseload of patients that needs to be evaluated for screening of pulmonary hypertension if they do have BPD. We know that guidelines since 2015 have advocated for the screening by echo at 36 weeks for pulmonary hypertension in premature infants who have BPD or who are on oxygen or respiratory support at that point. And so, because it is something that comes very often in our practice, and especially if you're a trainee learning neonatal hemodynamics right now, it's probably, you see many of these patients at 36 weeks that you need to evaluate to make sure that there's no signs of pulmonary hypertension. And sometimes pulmonary hypertension or high RV afterload can be something very subtle, and this entity can be coming with, many elements. There could be an ASD, there could be post-tricuspid shunts, there could be some degree of pulmonary vein issues. So all of these things needs to be evaluated, and I felt it was a good way, in kind of a back to basics, to do a video review of some of these cases, and to showcase a case of severe, a case of moderate PH, two cases of mild pulmonary hypertension, and one case that are related to a post-tricuspid shunt, so high pulmonary arterial pressure secondary to flow and pressure transmission, and not really to high pulmonary vascular resistance or pulmonary vascular hypoplasia. I did put the algorithm here that we use in Quebec. This was developed in collaboration of multiple experts across various institutions in order to harmonize the practice. And basically, what we do is that we screen premature babies at around 36 weeks of corrected gestational age if they're still on oxygen respiratory support using echo. We do start earlier if there are concerns, either by the medical team that thinks that the patient is symptomatic, or if the baby is small for gestational age, growth restricted, born less than 25 weeks and at higher risk of developing lung disease or pulmonary vascular disease, or still on invasive respiratory support around 32 weeks corrected age. And so we do classify as mild, moderate, and severe, and based on that, we have different pathways of management. As well, we have put here some of the criteria that we use to decide if we need to go to the cardiac cath. And here we have our PH severity scheme that is inspired by the Pediatric Pulmonary Hypertension Network, where, of course, this is the continuum and spectrum of disease of various severity, and sometimes one patient may not fit exactly in one box. but the importance to recognize pattern in order to tailor the management of these patients. And really what dictates outcomes is often when there's already alteration of right ventricular function. So we'll start with the severe case. So this is an extreme premature newborn born at 26 weeks, required intubation and surfactant from the first days of life. This patient was born from a pregnancy that had precipitous labor and incomplete antenatal bedmethasone coverage. And eventually, this baby was extubated to CPAP and actually remained to CPAP up to 36 weeks. There was one echo done at 1 week of life that was unremarkable. There was a ASD at that time that was left to right, and there was a small PDA that was restrictive, and that was left to right, so very tiny. And actually, a repeat echo 2 weeks later shown that the duct had closed, and there was really no great concern on these echoes at that point. This patient really had an uneventful stay, but at the time of the screening, the patient was on 25 to 28% oxygen, and the blood pressure when the baby was calm was 65/32. You can even see it here. Sometimes we mark it on our echo clips. There was a chest X-ray that was done showing, some heterogeneous opacities, and basically, um, we went on and we arrived to do targeted neonatal echo for screening. So this is the parasternal long axis view. We see here the LV, we see the septum, we see on top this RV. This is a very hypertrophied wall for an RV and a hypertrophied septum, especially on the side of the right ventricle. And we can see already that the RV looks quite dilated, even in the parasternal long axis view. Usually here, this would be very tiny and very slim. And as we put an M mode through it, which tracks the motion of all these walls along the line of interrogation, you can see how the diameter of the RV is quite impressive, almost the size of the diameter of the LV. We see, though, that the LV has some preserved adequate function with the motion in systole and in diastole. So there's relative preservation of what we find to be the shortening fraction of the LV, but don't forget that when there's pulmonary hypertension, the septal motion becomes impacted by the relationship between the RV and the LV pressure, and so these metrics may not be fully representative of the underlying LV systolic function. So here we've put some color. We see that there's flow through the aortic valve. There's flow through the mitral valve as well. So there's no signs of, mitral or aortic stenosis or insufficiency that may be leading to LV failure and eventually to post-capillary phenomenon. As we sweep towards the posterior in parasternal long axis, we see the RV inflow here. We see the tricuspid valve, and we see this jet, which is tricuspid insufficiency. So it's not uncommon to see that as the RV becomes dilated, we lose coaptation of the valve, and now we start seeing more and more TR appearing in some of these patients. This is the right atrium. So now we are shifting to the parasternal short axis view. We see the aorta here, we see the pulmonary valve here, the RVOT. There's blood flow going through the valve, so it tells us there's no kind of obstruction there. There's no big clot, there's no clear stenosis or atresia, and we see the branch PA. There's a bit of acceleration here at the level of the left pulmonary artery, but we see nice flow in the right pulmonary artery. And so if we take a Doppler at the RVOT, we see here the pulse wave Doppler and the velocity of flow. And we can see here that we have, a very sharp acceleration and slower deceleration. So it looks like almost like a triangle. And this is a sign that there's already, high PVR or high RV afterload. We call this that pulmonary acceleration time over RV ejection time. And the ratio is less than 0.3, which makes us concerned that there's underlying high RV afterload. Then we put color. We see here 1, 2, 3, four pulmonary veins. So at least by color, we can see very well the pulmonary veins. And then we put color here over this is the tricuspid valve, the RV that it looks quite dilated, the pulmonary valve that opens and closes nicely. We can see again the TR into the right atrium. This is the aortic valve. So now we see in slow motion the short axis of the RV and LV, and we see that this LV in systole gets completely pancaked by the right ventricle, which looks very globular and dilated with hypertrophied walls. So this tells me already that I have a concern for suprasystemic RV pressure compared to LV pressure. And you can see how, there's definitely flattening to bowing of the septum inside the LV cavity. There is no clear large VSD, at least from the apex to the mitral valve as we sweep. So no big shunts here. Again, this is for the pulmonary veins where there's no obvious concern, at least by color, but we would need to Doppler all these four veins. This patient had Dopplers of the four veins, and all of them were biphasic or triphasic and of a low velocity profile. Here, this is an apical four-chamber view. We see the RA, the LA, we see the RV and the LV, and we can see even how the LV looks smaller, probably because there's less preload coming back from the pulmonary vasculature, which underfills the LA and the LV to some degree. So that could be a possibility, or just because of the RV-LV interaction where the RV becomes very distended and dilated, and obviously it's a fixed cavity, so it will have a tendency to shift to the septum and occupy more space. We can see that the RV looks quite muscular, but the tricuspid valve seems to be going up and down quite nicely. So for this, it seems like the systolic function to some degree is preserved. There are many markers of systolic function of the RV. One of them is what we call the TAPSE, which is the tricuspid annular plane systolic excursion, where we look at the motion of the tricuspid valve as it goes up and down, and we use M mode for this. And values around 1 centimeters are considered normal in babies that are close to term, near term, or term. So at least this marker of systolic function is adequate. There's also what we call the fractional area change, which is the area in diastole compared to the area in systole, and values above 35% are typically reassuring / normal. And this patient had about 25% of FAC. So one of the markers of RV systolic function was diminished. So here we see the RV again, which looks much more prominent than the LV in this view. And then we can see that when we put a color box, there's red flow in diastole, so filling, because blood is coming towards the probe, and then blue when the blood is coming away from the probe, which is tricuspid regurgitation. So we can see that there is blood flow going back towards the right atrium, which if you put line of interrogation and you obtain what we call a continuous wave Doppler, you're able to estimate the velocity of this jet. And so it informs you on the speed that generates the RV between the RV and the RA during the peak of systole, right? So you have the QRS, you start building blood flow going towards the right atrium or tricuspid regurgitation, and then eventually you enter the diastolic portion of the cardiac cycle. And one important thing is that systolic to diastolic ratio is also a marker of cardiac performance. And so typically you're not supposed to spend as much time in systole than in diastole. Most of the time, actually, adults will spend 2/3, 1/3, 2/3 in diastole, 1/3 in systole. And in babies, it's often half-half, I would say, because they have faster heart rate. But you can see here that you're spending definitely more than 2/3 in actual systole because the RV is trying to eject and is facing possibly a high afterload. So that's one marker. The systolic to diastolic time ratio informs you that this RV is struggling. So we have like the FAC and the this marker that is of concern on top of the significant RV hypertrophy and dilation. So here we get a first TR jet, which is not completely well aligned because the cursor is going that way and the jet is, kind of going this way or this way. So we get 86. And then as we try to align ourselves a bit better to be completely through the jet, you can see here, we obtain a velocity of 4.9, which if we put in the modified Bernoulli equation, which is 4 times v squared, gives us 96 millimeters of mercury. And then we repeat a few times to make sure we're getting an appropriate tracing and a reliable value. Here we get 91, here we get 93. So really in the range of 90 to 96 millimeters of mercury. We see here this RV that's very dilated. We can even see it in 3D. So this is the lateral wall, septal wall, and this is the cut posterior anterior. And we can see that this is an RV that looks very hypertrophied and quite dilated. This is the subcostal view. So this is the right atrium, left atrium, atrial septum. And we can appreciate here that there's already potentially a defect across this septum. And here the defect is actually an atrial septal defect, and it's completely left to right. So going towards the probe, so from the left atrium and filling into the right atrium, which tells me that there might be a component of volume that is overloading the right ventricle. This is the short axis in the subcostal view, and this is just to show you that sometimes in some babies, you may not have chest views that are accessible because they're lung disease or because of a tracheostomy or because of various other reasons. And sometimes you can appreciate the septal curvature even in this short axis view in the subcostal area where you see that there's bowing of the septum in systole. And don't forget, it's really during contraction that we want to appreciate the relationship between the RV and the LV because it's in systole that the alpha tracts are open and that the corresponding ventricles will equalize their pressure with the great vessels or the corresponding great vessel. So you assume that the RV pressure equals to the pulmonary artery pressure in systole, and you assume that the LV pressure equalizes with the aortic pressure in systole. And so in systole, if you get bowing of your septum from your RV towards your LV, it informs you that the RV pressure and by definition, the pulmonary arterial pressure is probably higher than the systemic pressures. This is again a view of the interatrial septum in short axis where we see this left atrium to right atrium shunt via the interatrial defect or this atrial septal defect secundum. And then here we saw the color. This is the arch. That was within normal limit. And here I've made like a little schematic to show you. So we have the right atrium, right ventricle, pulmonary artery. In this context, there's no duct for this patient. The duct was closed. And then eventually goes to the pulmonary vasculature, comes back by the pulmonary veins into the left atrium, left ventricle, and eventually aorta. So we know from the blood pressure we took on this patient at the time of the echo, it was 65/32. Which means that the LV systolic pressure is 65. We know that diastolic pressures are very low typically, unless you have diastolic dysfunction, because the LV relaxes nicely and gets filled during diastole. So you're never at zero because there's never a moment that the LV is completely empty. There's always some blood creating tension on the wall. So it's something between 3 to 5 millimeters of mercury. And during diastole, the pressure with the LA will equalize because the mitral valve is open. So these two will have similar pressure. So it's 65/5, and the pressure in the atrium is around, 3 to 8 or 3 to 6, depending, but typically a very low pressure system. We know here that there's a bit, a generous secundum ASD. So there's a left to right shunt, which sends blood into the right atrium and on top of the pulmonary venous drainage. So this may be contributive to some degree to, higher RV pressure by flow, but typically at this age, it's rare that ASDs have that much impact yet on the RV pressure or pulmonary pressure. We know that the TR was 96, so since it's a gradient and you want to have the value of your RV systolic pressure. Um, 96 of TR plus about 5 gives you 100, 101 of systolic pressure, which is equal to the one that is in the pulmonary artery, unless you have an obstruction here, or pulmonary embolus or something like that that's blocking, or stenosis of the pulmonary arteries. And so if we know that the systolic pulmonary arterial pressure is 100 and the systolic systemic blood pressure is 65, we get a ratio of 1.7. And so this patient is in severe pulmonary hypertension because of this suprasystemic status, plus degree of RV dilatation and RV hypertrophy, and some degree of RV systolic dysfunction. So this patient was actually started on NO and sildenafil eventually. We gave INO through nasal cannula. Just a caveat to that, these are all off-label because there's just no great RCT or studies that have been done in babies with prematurity and eventually bronchopulmonary dysplasia, pulmonary hypertension to show that it helps. But this patient was started on INO with per echo, and we saw a good response. And so sildenafil was introduced. Eventually, INO was weaned 2 weeks later. The patient was discharged on home oxygen, which was weaned in the first year of life, and sildenafil was then weaned a few months later after the RV pressure were considered to be completely normal. And this patient is doing relatively well in the community, now off sildenafil and off oxygen. The next case is an extremely premature infant born at 26 weeks gestation. This patient had growth restriction at birth in the context of maternal hypertension. And similarly, this patient was still on CPAP at 36 weeks, actually CPAP of 5 with a value to around 30%. And so a targeted neonatal echo screen was done at 36 weeks. And at the time, the exam was completely benign. There was no hepatomegaly. Heart sounds were completely normal. There was no murmur. It was good perfusion. And actually, this baby had really, no symptomatology of anything except, some residual lung disease of prematurity. The patient had a first echo that was done at day 1 of life, actually, that had shown not much findings. Like the PDA had already closed, and there was a PFO that was left to right. And so at 36 weeks, the echo was repeated, and this baby was 76 on 41. We repeated the blood pressure per echo was closer to 85 of systolic towards the end of the echo. And so this was taken over the right arm. You can see that the lung showcase some signs of bronchopulmonary dysplasia, where there's granular opacity everywhere that are typical to the scarring related to BPD. So this is the parasternal long axis view. We can see the aortic valve, mitral valve opens nicely. This is the LV, the left atrium, the RV. You can appreciate here how the RV, doesn't look quite distended, at least from this view. We always obtain M modes on these patients. So then here we do a sweep towards the posterior, and we see the RV, the inflow, or the tricuspid. So RV, tricuspid valve, right atrium. And then when we go anteriorly, we see the RV outflow tract, the pulmonary valve, and the main pulmonary artery. We can put color over this. So this is the RVOT, pulmonary valve, pulmonary artery, the long axis view. And when we put color, we see there's like a little flash of pulmonary insufficiency, which is this red flame here, and then blood flow going through the actual valve very smoothly. And so we try to obtain a continuous wave Doppler, and we see that we get a value of at least 15 millimeters of mercury of gradient between the MPA and the RV, which tells us that if the RV and diastolic pressure is around 5 millimeters of mercury, we have about 20 to 21 millimeters of mercury of mean pulmonary arterial pressure. We then took a pulse wave Doppler at the level of the RVOT, which provides us information on, for example, the stroke distance if we do an area under the curve, or we can also do the pulmonary acceleration time on RV ejection time, which here was 0.17. We use the cutoff of locally of 0.3 as a concern. So if you're less than 0.3, it's a sign that you have a very short acceleration time relative to the entire ejection time of the right ventricle, which can be a sign that there's high pulmonary artery afterload or RV afterload. We also sometimes see like a mid-systolic notch. So you can see here, it looks like a W a bit. Here also. Here also. So this mid-systolic notch is thought to relate to when there's high afterload, there's blood flow that kind of gets during injection, part of it gets inside the pulmonary artery, which has a certain elasticity. And so there is a capacitance to it. So you get a recoil of this pulmonary artery midway during the cardiac cycle, which creates the second acceleration within the pulmonary artery. And so it's a sign of higher RV afterload. This is a short axis view. We see the aortic valve. We see the pulmonary valve. We see the collar going through it. And then we can obtain a similar Doppler in that view. And we can see also here the mid-systolic notching, mid-systolic notching, mid-systolic notching. That concerns us for high RV afterload. And we can see here that we left a comment saying that the patient was calm at the time of the evaluation. So in B mode, we have the pulmonary valve that opens and closes and divides into two branches. So the right and left pulmonary artery. And then as we sweep down, we can appreciate the two papillary muscles, and we wonder if there's a bit of septal flattening here, but the RV doesn't look dilated. It looks, about half the size of the LV, which is very normal. And so when we kind of stop at the mid-papillary view, which is the view to appreciate the septal deformation, actually the LV looks pretty round, but there are moments where you wonder if there's slightly a bit of flattening of this interventricular septum. So just as a reminder, this is the RV on top, this is the LV, and this is a view from the short axis. So it means from like kind of on top of the two papillary muscle of the mitral valve. And you can see the septum here behavior, and that at the peak of contraction, you want this LV to be completely round, which tells you that the LV pressure is, higher than the RV pressure. But if there's a bit of flattening, you start wondering, could there be, at least 2/3 to isosystemic PA pressures? And so I did create a kind of a freeze to show you what I mean about the flattening. You can see here that you have occasionally a very round septum, and occasionally you see, if you go frame by frame, during systole, a bit of this flattening that gives more of a bit of a D type of a conformation to the left ventricle. And then I think you're going to appreciate it here. So then we do a sweep. This is the PDA view. So we see the aorta, descending aorta, the pulmonary artery, and we can see that at least we don't appreciate any obvious shunts. Sometimes you can miss, right, the left shunting PDAs in suprasystemic pulmonary hypertension, but here with this kind of configuration, we would not suspect that this patient is in a suprasystemic pulmonary hypertension crisis. And so with this sweep, we really don't see any connection or any flow between the pulmonary artery and the aorta. So this PDA is closed. This is a view where we do a zoom on the pulmonary valve, the aortic valve. We see that it's trileaflet whenever it opens. We see the left coronary artery and the right coronary artery, and we always make sure that in diastole there's red flow through the left coronary artery, unless it's not been documented, if it hasn't been documented before. And here I've put a freeze to show you what I mean. So you see the aortic valve here, and the red in during diastole. So when the valve is closed, there's flow into the coronary system. And you can see here the right coronary artery and the left coronary system in a still frame. So then we have this view where we first see the right ventricle, and we can appreciate the RV in size is smaller than the LV in size. We see the left ventricle here, the right atrium, the left atrium, and we can see that both of them are at least visually contracting well. And I can tell you the ejection fraction of the LV was within normal limit. Here we put color, and we see the inflow of both valves. So there's good filling of both the RV and the LV. Here we focus on the RV and then eventually on the LV. And we obtained again a TAP-C to see the motion of this tricuspid valve. And we got 1.12 centimeter in the measurements of this motion, which is completely normal for that age. Then we lowered the velocity filter to see lower velocity flows, and we can appreciate a pulmonary vein here and a pulmonary vein here. And so we Doppler this pulmonary vein to make sure that it's biphasic or triphasic. There's no signs of acceleration or high velocities that would be something of concern for pulmonary vein stenosis. We also Doppler the inflow of the RV and the inflow of the LV to make sure that the velocities are within normal limit, so less than 20, here around 10, just to make sure that there's no signs of mitral stenosis or tricuspid stenosis. And also, as an indicator, we can see the E and the A velocity, so early filling at atrial contraction. And typically at this age, it's not unusual to see a similar velocity for both. We do obtain tissue Dopplers in all of our TN echoes. And in this particular patient, we had some fusion during diastole for some of the velocities, but they were all overall within normal limits for the age. This is a three-chamber view where you see the left atrium, the LV, and the outflow tract of the LV, the aortic valve, and the aorta. And you see flow going from inside to the outside. So there's no obstruction of the outflow tract. And here we obtain a Doppler in order to evaluate the left ventricular output, which was normal in this patient. So here we have views where you can see that my probe is a bit tilted in order to evaluate the tricuspid valve in every angle and in order to see where I could obtain or capture tricuspid regurgitation. And you can see here this blue flame is tricuspid regurgitation. And here we obtain different Dopplers. So you can see here that my peak systolic RV-RE gradient is around 70 or 68. And so we'll see how it compares to systemic blood pressure. And you can see here in the subcostal view, this is the liver, RA, LA, and we have basically a bidirectional interatrial shunt. So I've frozen it for you to see. This is blue, which means right to left, and this is red, which is left to right. So there are moments of the cardiac cycle that it kind of goes both ways, which means that some deoxygenated blood enters the systemic circulation through the interatrial level. This is SVC IVC view. We see the subhepatic veins here, which at least by color seems to be all blue, which means going away from the probe, which means that it's draining nicely into the IVC and into the RA. If the RA has very high pressure, you can get backflow into these vessels, and eventually it can reflect as a big liver or as retrograde flow in these subhepatic veins. So it would become red. More than 50% of the cardiac cycle. In the subcostal short axis view, we can appreciate again the LV. It seems quite circular from this point of view. And then from here, I'm showing the Doppler, which is low velocity and fully forward of the subhepatic veins. I'm also doing a Doppler of the SVC here. So this is the SVC going to the right atrium. And we can see that it's red all throughout, except for really minimal portion of the cardiac cycle, which are very normal with the breathing pattern to have some retrograde flow in the SVC. But you can see that the majority of it is forward. So it means that it's positive and coming towards the right atrium. If you had high RA pressure, you can start having a more retrograde flow into your SVC. And this is just the pattern of the blood flow in the descending aorta. So this is the spine here. The descending aorta runs along the spine, and then we obtain a pulse wave Doppler here, and we see the systolic upstroke and then the eventual diastolic period of the cardiac cycle. Here we have the branch BA, which are of good calibers, and there's no clear turbulence bicolor Doppler. And then we obtain what we call the crab view, which we see the 4 pulmonary veins bicolor, nicely draining. I've put even a little zoom on it. And the left upper, left lower pulmonary vein, right upper, and right lower pulmonary vein. But it's important to Doppler them, especially at the ostium. Color, depending on your velocity filter, may look completely normal, and still you could mask a pulmonary vein stenosis, which would typically show as monophasic or losing the physicity of your pulmonary veins, as well as very high velocities if there's a restriction to flow. And sometimes you won't be able to Doppler, or you won't see it bicolor if it's completely atretic, obviously. So here we see one of the right-sided vein. So this is the right lower pulmonary vein. This is the left lower pulmonary vein. This is the left upper pulmonary vein. And this is the right upper pulmonary vein. We see the Doppler below. And so for Dopplers, that looks completely normal. We also Doppler the 2 branch pulmonary arteries. We can see again this kind of mid-systolic notch here that is probably related to high pulmonary vascular resistance. And so as we do the sweep here, again, one last time in the subcostal, we don't see a duct or a shunt, and the arch looks normal with no obstruction. So if we go back for this patient, we had 76 over 41 of systemic blood pressure. And then obviously this gives 76 of systolic blood pressure into the LV and about 5 of diastolic blood pressure. We saw that this shunt was actually bidirectional, so it was going both ways, probably because the RV and diastolic pressure is a bit higher than 5 actually. And so we got a TR of 70, which gives an RV systolic pressure of about 75. And so this gives you an isosystemic pulmonary pressure. So 76 over 75. So we call this often a moderate pulmonary hypertension because you're in a situation that you're isosystemic. And there's a bidirectional PFO telling you that there's already maybe some struggle regarding the diastolic function of this patient. So this is obviously a patient that you want to follow closely and potentially, manage by optimizing the respiratory support, making sure there's not a lot of profound desaturations. Sometimes you want to make sure there's no concomitant injury to the lungs. So avoidance of infection, vaccination for the baby and the family, making sure there's no aspiration into the lungs if you're feeding the baby. And sometimes evaluation of the airway to make sure that this is not something that worsens the baby. And obviously, I always recommend that you manage these patients in a multidisciplinary fashion and with experts also in pulmonary hypertension in order to decide the best approach for this particular baby, especially if you don't have all the tools to evaluate these patients, such as the help of ENT or respirology and cardiology and neonatal hemodynamics in your own practice. So I'm going to stop this recording here, and then in the next recording, I will go over case 3, case 4, and case 5.